Well, good evening, everybody. Welcome to the Institute of Healthcare Management's Health Chat this evening with the fabulous Jeremy Hunt, MP. Oh, hang on. Sorry, no, that's not worked.
You're recording.
Hello, everybody, and welcome to the Institute of Healthcare Management's Health Chat event this evening with Jeremy Hunt, MP. We're delighted that we've got our two sponsors in the green room already, Richard Strong and Adrian Flowerday from respectively Allscripts and Docabo. The one man we do not have at the moment is Jeremy Hunt, MP. Unfortunately, he's voting in the House of Commons and will be with us as soon as he possibly can. Sorry, everybody, it's not enabling me to start the webinar.
Got it now.
Hello, everybody, and welcome to the Institute of Healthcare Management's Health Chat event this evening with Jeremy Hunt, MP. We're delighted that we've got our two sponsors in the green room right now with me. We have Richard Strong from Allscripts and Adrian Flowerday from Docabo, and we're delighted that they're here. They're going to say a couple of words in a moment. The one person we don't have in the room at the moment is Jeremy Hunt, MP, and that's not because he's not coming, it's because he's currently in the queue to vote in the House of Commons and will be with us as soon as he has done so. So we may have a few minutes wait for him to appear. The guy who we do have, of course, in the room as well is Roy Lilly. And Roy, I'm going to hand on to you in a moment or two. But first, I thought I'd give, first of all, Richard the opportunity just to say a quick welcome on behalf of Allscripts. And then, Richard, if you'd be generous enough to hand on to Adrian to do the same, and then back to me, and then we'll go to Roy to kick things off. Thank you.
Thanks, John. Welcome, everyone, to this evening's Health Chat. At Allscripts, we are really delighted to be able to sponsor tonight's session. Allscripts is a world-leading provider of digital healthcare solutions. We partner with many trusts across the UK, providing clinical systems that support those trusts in their delivery of high-quality patient care and ever-improving clinical outcomes. Once Jeremy arrives, I'm really looking forward to hearing an insightful conversation between him and Roy. And thanks for attending. Over to you, Adrian.
Thanks, Richard. Good evening, everyone. Again, likewise, we're delighted to sponsor this Health Chat event this evening. We've been involved as Docabo in the health space, digital health space for many years now with our remote monitoring solutions and our population health solutions. And I guess we'll be able to speak a little bit about that a bit later on. So really looking forward to the discussion, debate, the questions and the answers from Jeremy and Roy tonight.
Thank you very much, Adrian. So without further ado, Roy, I'm going to hand on to you. Let's have a short discussion around whatever topic you like, really, whilst we await Jeremy's arrival. Thank you.
John, thanks very much. Good evening, everybody, and welcome wherever it is you're watching. Actually, because you might be watching and recording to this as well. So thanks for watching. Well, as John said, when you have an MP involved in anything like this, they are at, of course, the mercy of the whips. There is an unexpected vote in the House tonight. Jeremy's told us that he's in the queue to vote. Of course, here they're still voting in person for the most part in the House of Commons in person, although they do have an electronic alternative for people who are sheltering. So he has to do it in person. And but actually, it does give us the opportunity to explore, I think, a bit more about what it's like from, if I may put it like this, the other side of the fence, the supplier side of the fence in doing business with the NHS during what has been a very tricky period. And both our sponsors, interestingly enough, I think have products that probably we would be looking to support us in normal times, but even more during the COVID period. And if I perhaps started with you, Richard, I mean, one of your product lines is is medical records that between health and social care, health and primary care, and that very important interface. I mean, I thought one of the most interesting things to come out of the first wave of COVID, if I can put it like that, was Matthew Gould's memorandum to everybody that said, don't worry about GDPR, just do what's sensible. And of course, it kicked over all of the nonsense that we have to put up with about confidentiality. Not that it's not important, but you know, a lot of people think the NHS is overcautious, and I'm one of them. So, Richard, I mean, the question is, like, how has it been for you, I guess?
Yeah, I mean, like everyone else, COVID has been a really challenging time for us. I mean, first off, I'd like to acknowledge the phenomenal work that the NHS did generally. Our clients just reacted in an incredible way. And we were there really to support them, nothing more than that. I think you pointed to a really important thing that happened, and that was around that opening up, if you like, of rules around privacy and data sharing, which enabled our clients to very quickly put in place things that maybe in a typical project might take 6 months, a year, 2 years. Actually, they did incredibly quickly. So we were able to join up the ability for GP data to be available as patients turn up in A&E within the workflow, so clinicians could see what medications the GP had been prescribing for them without having to take PPE off, without having to, you know, go get on the phone, etc. And they could then continue that care for the patients. And the same as patients were discharged, we were able to rapidly turn on feeds to share discharge information, discharge medications back to the GPs. So I think, you know, the first thing I would say is we really saw that ability to share data because it was important and necessary to do it. It was about people, you know, enabling that to happen. I think the second thing was there was suddenly from our clients, there was an openness to making decisions and realizing that perfect wasn't required. It was about getting the best available, which meant people suddenly didn't have so much vested interest. Everyone was working to the same goal, made decisions quickly and got stuff done. So I think those are the first two things that I would point to that changed for us. And that enabled us to work with our clients quickly to, you know, do things for them and with them collaboratively to achieve the same common end goal.
Interesting. John, just before I go to Adrian, I've just had a message from Terry who's, yeah, okay, so you're across that. Right. Adrian, coming to you, of course, your stock in trade is remote health monitoring. I mean, it's easy to say remote health monitoring, but you've got some really sophisticated products. But I would imagine some of the very basic product lines that you've got had a new lease of life in trying to look after people at a time when they were sheltering. It was very difficult for GPs and others to do home visits and so on. What's happened to you? Are you just deciding what colour your next Bentley is going to be, or
it's the yacht, really? But
has it been?
Well, you know, we've been battling with this for many, many years. Remote monitoring, keeping people out of hospital, seeing the problems before they end up calling an ambulance has always worked for the patient. It's always worked for the money, but it's just been quite difficult to get kind of clinical buy-in. And what we've seen this year really is now that clinicians kind of can't easily see their patients, it's suddenly gone up the agenda. So yeah, we've seen a significant increase in business. In Liverpool, we were monitoring about 2,000 patients, and then they suddenly, you know, we up to about 3,500 patients who were on the shielded list because they couldn't see anyone. They couldn't see their GP, they couldn't see anyone. And how do you look after those, you know, high risk, shielded, vulnerable people when they're not allowed to go out? So we've seen kind of significant increase there. So, you know, I think it's put remote monitoring on the map. I think we've done a lot with social care and care homes, and there's a lot of energy now going into care homes, as there should have been many years ago, but it's actually hopefully starting to get the focus of digitizing, giving them resources and everything. So I think we're seeing quick decisions, like Richard said, yeah, much quicker decisions. We've had to add shed loads of functionality. So that, you know, the latest one is oximetry. You know, NHS England bought a load of oximeters. So how do we get that data in a low cost manner rather than someone phoning everyone every day? So, you know, we've added that capability. We've got long COVID question sets we're putting in now to look after some of those symptomatic long COVID patients. We've had the remote monitoring framework out of NHSX that was put in place pretty rapidly. So people can procure remote monitoring. Obviously, Richard and his team Matthew Gould's team very much pushing technology and remote monitoring. So for us,
suddenly his agenda has just boomed, hasn't it?
Oh yeah, and how do they manage that boom and what they should be doing? But,
it is tricky. I mean, I've been in and around the NHS for 40 years, I think, and I've seen more progress on the IT front in the last 4 months than I've seen in 40 years, and I'm sure you've seen it as well. And and Richard, one of the other products in your menu, your offering, is around population health, and that's really moved up the agenda now, isn't it? Because there's clearly a link between general population health and susceptibility to COVID, and health status, living conditions. All of that data now has suddenly become very sexy data to understand.
Yeah, absolutely. And there are lots of projects going on in and around various parts of the UK and across the whole UK to understand how best now to make use of that data for long-term care. And with population health solutions, you can take all of those things in and then start feeding that in through machine learning and other things to actually put that back into the clinician's point of care, to be prescribing, for example, extra exercise to start reducing the BMI of the patients, for example, or prescribing different diets.
Well, there's clearly a link, isn't there, between BMI and COVID and social deprivation factors as well. I mean, what do you use, ONS data or something? Do you actually load the data, or do you just provide the framework for other people?
Typically, we're providing a framework for other people to load data in, and what we take the data in from multiple different sources, whether that be secondary care, primary care, social care, other places. It could be ONS type data, and then normalize it in a way that then people can look at it in a standardized kind of way and start applying analytics over it. And like I say, ultimately you can then start paying that back into automatically feeding data based on different cohorts of patients into the clinicians as they're doing their consultations. And obviously, ultimately, then you hook that into video consultations and all the rest of it.
Yeah, I was very interested that you used the phrase machine learning and not artificial intelligence. I always tell people off for using artificial intelligence because it doesn't exist. We've got machine learning, and the machines have to learn, but they aren't artificial intelligence. So and that's, and the reason I did that is because I interviewed the head of IBM's advanced technology, and I said to him, well, let's talk about artificial intelligence. He said, it doesn't exist. This is the head honcho from IBM. And so I learned that lesson pretty quickly, that it doesn't exist. I was thinking, all that sort of raft of stuff that you've got is in its predictive sense. I mean, how confident are you? I mean, I don't know, perhaps we can do it now. I don't know, because I'm not sufficiently familiar with your products, but I mean, how predictive is it? How reliable is it? How much could I actually plan a population health strategy around the data? Do we have enough data at the moment to be able to do that under any circumstances?
Yeah, I mean, I think
Jeremy is here now, by the way.
Okay, fine.
As I say,
answer the question.
Yes.
Yeah.
But we should move to Jeremy quickly now.
Yeah. No, just finish the question. Do we have enough data?
Yes, we do. Absolutely. And there's lots of examples around the world where you can pull in all sorts of other things like weather predictions, information about big sporting events, etc., that are going on that will have impact on traffic patterns and all of that to be able to predict.
This is a fascinating conversation for another time. Yeah, we're gonna. Jeremy, good evening. Where are you? You're not on my screen.
Hi, Roy. Nice to see you.
Where are you? Oh, there you.
I'm in Parliament. You should be able to see that.
Well, I mean, you need not be in Parliament, because we all know. I mean, the other day I pretended I was in Australia or something with Zoom.
That's right. That's right. Anyway, I've just been voting to give our spies more powers, and it just shows that the world has not stopped because of COVID. Our spies are still spying. So there's a little bit of good news for you.
It's extremely comforting, but I rather suspect the people in Salisbury might see that differently.
They might do, indeed. Yes, it's not just our spies that are still spying. Everyone.
Well, that's good. Well, our spies are good spies. Everybody else are bad spies. Yes. It's great to see you, and see you looking so well. I mean, I must start by asking, how have you been? Because everybody I know who's been into number 10 has caught COVID.
Yes, well, thank you so much. I haven't actually. I'm one of the 90%. I did actually do the antibody test, and I was desperately hoping that I'd caught it, like everyone. But no, I haven't had it so far. Mind you, in this place, you know, there are lots of people a bit worried that it could be around every corner. But no, so far, me and my family have been fine. But thank you for asking. I hope you've been okay as well, Roy.
Yeah, I've been banged up on the sofa. I mean, it's you know what a lazy layabout I am. You know, this suits me very well.
I thought you might have been on the golf course, but there we are.
Right, listen, I saw you in action in Parliament earlier today with Matt. I thought you asked him a really interesting. I mean, you got the bum's rush for an answer, but I thought it was quite an interesting discussion point to get us started. When you were saying that you wanted to test everybody once a week. And I thought, I don't think we're going to be able to do that for a little while yet.
The thing is, Roy, that the uncertainty is killing us all at the moment. It's absolutely terrible for business. You know, and when I was Foreign Secretary, and even before that, the last time we did one of these chats, towards the end of my time as Health Secretary, we were in the Brexit negotiations. And the thing that business hated most of all then was not whether we were in or out, but the uncertainty, not knowing. And we're back into that now. And it's also uncertainty from a health point of view, because no one really knows, is it still dangerous? You know, are we getting better at treating it? And the only way we can give certainty, we have no idea about these vaccines. I think we'll probably get one. But it looks like we'll probably only want to give it to half the population because we'll be worried about the long-term effects on children and so on. But we may not get a vaccine. And the only thing we know is that if we can pick up all the asymptomatic carriers with a high degree of certainty, then we will be able to carry on life as near to normal as you can imagine. And that means being bold. And so my argument is, look, even if it's next March, next April, next May, it's 10 million tests a day. We're probably going to be on 1 million tests a day by Christmas. But, you know, the British state, if we put our mind to these things, we can scale up pretty quickly. Let's have a date when we can say, let's say the 1st of April or the 1st of May, by this date, everyone in the country once a week. And then you can be confident that basically life will get back to, you know, some degree of normality. And it doesn't matter if it's a long way away, people just need to know. And then if the vaccine arrives, it's upside. If the virus calms down and we don't have a huge second wave, it's upside. But we just got to get ourselves into a position where people know, have some sense as to what's around the corner.
I want to ask like this question. I don't want to ask it from the kind of from a sort of an aggressive point of view. I mean, it's about testing. I interviewed Dido the other day. I mean, she was, God, she's like bombed out busy, but she found time to have a chat with us. And it's clearly like she's busting a gut to sort this out. And what I don't understand is what's gone wrong with I mean, I've got a bit of an idea what's gone wrong, but I'd be really interested to get your view, because you've made testing the select committee's, you know, thing right from the off because of the experiences that you've seen in other countries. But what is it? Why isn't it working? Or is it working and it's just sort of now attracted the reputation for not working and it can't scrape that off its shoes? What is it, Jeremy?
Well, first of all, I think I should do the kind of mea culpa bit in this, because, you know, I did huge pandemic preparations in the 6 years that I was Health Secretary, the biggest one, Operation Cygnus in 2016. And you can look through the whole report, which was actually leaked to The Guardian, so everyone can read the recommendations from that report. There's not one mention of testing in that whole report, because we were focused on preparing for pandemic flu, not pandemic SARS. And
well,
so
you know, that's a really interesting point, because when I, as you know, as a leader of council down in Surrey at one stage, and I did the Easing World Civil Defence College civil resilience, or whatever the course is. It's a, you know, and I've done that sort of pandemic scenario and all the rest of it. And, you know, you get civil disobedience and you get shortages and rationing, and they throw everything they can at you. Never once did we ever look at testing. It never came up as an issue in the scenario planning that they teach you at the Civil Defence College. And the fact that you didn't, you know, I mean, I'm not surprised at that, because I don't honestly think it ever crossed anybody's mind.
Well, I'm not a scientist, but we had a blind spot across our scientific, political, medical establishment. And we shouldn't have, because we had SARS in 2002, MERS in 2014, but we had that blind spot. So we need to address that. And actually, I think this new sort of Robert Koch style institute that Matt Hancock's talking about setting up is the right thing to do to address that. But then what happened was, because we weren't able to do much testing, but because of that, we also embarked on the wrong strategy at the start, where we actually publicly abandoned testing on March the 9th. And we announced at the Downing Street press conference, we're now moving to phase 2, and we're stopping community testing, which is an extraordinary thing in retrospect. When we realized that was wrong,
you couldn't have carried on testing, because you know, Public Health England, they'd had their budgets busted. They were funded for, what was it, 10,000 tests a year for doing, you know, like ordinary testing. They were doing 7,000 tests a day at one point, without the resources, without the money, without the infrastructure. I mean, they were busting their backsides to get testing, and it was clear that they couldn't expand anymore, and the only thing you could do was ration it.
Well, I think that in a pandemic, you find money for these things, but we didn't want to do more testing at that point. The strategy was actually to stop testing once you had community transmission. Once the transmission stopped from being people who were coming from overseas, that you were tracking down everyone. Now, we obviously now know that wasn't the right approach, but the result was that we started doing the testing in a great big hurry in April, and Matt set his famous 100,000 tests a day by the end of April. He basically gave the system 4 weeks, and he you know, deserves a lot of credit for that, because he galvanized the system. But the problem with doing it that fast was that literally the only model that can work is a centralized model if you're doing something that fast, when actually we can see from Germany and other places that the most robust test and trace model is one that taps into local councils and basically says to local council leaders, look, you're in charge of test, track and trace in your own areas, and gets them competing against each other as to who has the best test, track and trace system, because they've all got local hospitals with laboratories, local universities with laboratories. And I think that's the model. It looks like we may be starting to move to that now, with people like Steve Rotherham in Liverpool being given more control over his local test and trace model. But I think if you ask me the reason why we've struggled, it's because we've got a centralized model and we need to go much more local.
But what do you think about local? I mean, I found out a really interesting point today that maybe you're across, maybe you're not, but I discovered that actually the councils who are asking to do their own test and tracing, we think that they're doing it with, you know, within their normal approach. Actually, 60 of them have spent quite a lot of money on buying CRM systems from the private sector, operating track and trace themselves. They're effectively duplicating certainly the technology centrally, locally, from what we were doing centrally. And I don't think people are aware of that.
Yes, but I think the other reason, but so just to conclude what I was saying, so I don't think I don't think the problems you had are in any way Dido's fault. It was the speed that the instructions she was given was to do it so fast. But the other reason I think that doing it locally is a good idea is because, you know, bottom line, if you're called and told you've got to stop going to work for 2 weeks and stay on your own, if you're called by your local council and told that, possibly even by people who could check up on whether you actually do what you're asked to do, I think you're far more likely to comply than if you're told by someone in a call centre hundreds of miles away. And so that's why I think we have started to go more local. And I think the quicker we move in that localized direction, particularly if we're going to do what I'm now arguing hard for, which is this mass population testing, which I think is the only way I can see out of the riddle.
If you were going to do mass population testing, what would the mechanics of that be? Would it GP surgeries, hospitals, or pop-ups in high streets? I mean, what's the interface? How do you see that?
I would basically say this is the responsibility of every local council to set up the system, and I would let them work out all those things. And it might be different solutions in different parts of the country, but you want this to be nimble and to happen quickly. And I think you need to tap into the networks that those local councils have got. The one thing that I think the government could do centrally is, I think what you want is you need an app that records your COVID status, whether you've got it or not, and records when you had your last test. Because I think then you can, one of the ways that you could boost compliance is you could basically, you could say to restaurants, you just need to ask people to show their app to show that they've had a test in the last week. And that way, the other people in the restaurant or the other people in the office or the other people wherever it is know that they are secure because everyone in that building has been tested in the last week. And that's how you start to get confidence back. That's basically what happens in, well, I hesitate to use this comparison, but that is basically what happens in China. That's how, and you know,
China are testing 9 million people in one city.
In one weekend, yes, in Qingdao, the city of the beer, the famous beer for anyone who drinks Chinese beer. But the thing is that, you know, I as Foreign Secretary, I spoke out against the Chinese way of doing things on many, many occasions. So I defer to no one in this respect. But the uncomfortable truth is that people in China today have more freedom of movement than people in Britain. And that you can go anywhere in China. And they do that because they use technology to check that the people who are moving around are free of COVID. And that's, until we've got a vaccine that works, ultimately, that is going to be the only way that we're going to crack this.
I mean, I am drawn back to the beginning of the app, and you know what a shambles that was. Why is it everything we've got to do is world beating, and we've got to do it ourselves? Why don't we just ring up China and say, "Hey, can we have a license for your app?" I mean, what is wrong with us?
Well, I think look. There's criticism that's justified, and we've talked about a few things, Roy. But I think actually there's also times when you have to give the government some slack. And I think the Singaporeans tried to develop this app, and it was the best around. But even they couldn't deal with this problem on Apple devices. If you haven't actually got the app open, it doesn't record who you've been near. It works on Android, but not on Apple. And because Apple, outrageously, in my opinion, wouldn't cooperate. I mean, you know, for goodness sake, in a global pandemic, why on earth aren't you prepared to, just for once, be cooperative? But they wouldn't. And so I think we were following the best, we had the right ambitions, if I can put it that way. But what you have to do in a pandemic is be prepared to change course very quickly. And when it became clear that the tech giants were going to be unhelpful, and even Singapore couldn't crack it, then you have to move on. And Singapore did that, and Germany did that, and then we did it. But I don't blame them for trying, because actually that app would have been fantastic if only Apple had been prepared to be more helpful. And by the way, if the United States government had been smarter at tackling COVID, that is the one government that could have put pressure on Apple to get them to cooperate, and they didn't.
Let's look at what's been happening today with the palaver with all the mayors and what have you. I mean, it is. I'm very surprised at Andy Burnham. You know, threatening to take the government to court. You know, really using his taxpayers' money to. You know, Andy, come on, wake up. I mean, what's gone wrong, do you think, with the relationship with the mayors? Is it just politics? Is it that they're Labour territories? They're not going to cooperate with the Tories. They're going to make the Tories look as stupid as possible because they want to get elected and blah, blah, blah. Or are there really insurmountable problems that Manchester alone can't put up with and Liverpool has? Well, how do you read that?
Look, of course, there's some politics. I'm a politician. Andy's a politician. Nicola Sturgeon's a politician, and you know, none of them would be human beings if they weren't thinking about the politics of the situation that they're in. But I think there is a genuine frustration and anger in some of the northern towns and cities that have been effectively on what we now call tier 2 since July. They haven't seen the virus go down, and now they're being told they're going to have to go to potentially to go to tier 3. And there is a real frustration that you know, the sacrifices they've been making over the whole summer when the rest of the country has been getting back to normal haven't been paid off, and it just seems to be getting worse. And so I think there is an element where that's why I think we should be trying to go for more localized solutions. I do actually think that all local leaders, local mayors, first ministers should belt up when it comes to a lot of this stuff, however justified their complaints are, because in a pandemic, compliance with public health messaging is very, very important. So you don't want to give the public an excuse not to comply with whatever messages are being given out by the government. So I do think it would be immensely preferable if these debates could happen in private and not in public. But I do think there is a lot of genuine anger. And one of the things that is perhaps not being noticed enough is that we do appear at the moment to be, in a good way, in the Italy situation in the first wave, where they actually contained the virus quite successfully in the north of Italy and stopped it getting down to Rome and Sicily. And so those northern lockdowns, although they haven't brought down the infection rates inside their cities, they do appear to have helped to contain the virus from spreading, unlike what happened the first time around. So this is an incredibly tough thing to say if you happen to be living in those cities, but it is actually nonetheless the case that we have done better as a country second time round than we did the first time.
There's a latency though, isn't there? That's the problem. We don't really know what the numbers are going to look like, you know, next week. I mean, it's interesting, isn't it? Elmbridge, which is not far from your constituency, that's been moved into tier 2. Why? Because it's a commuter town.
Yeah.
You know, people, almost nobody who lives in Elmbridge works in Elmbridge.
Yeah.
They're all on the train or what have you. So, I mean, it's curious the way, you know, that it's creeping around the popular. I mean, look, I think you kind of touched on it, didn't you, earlier? If somebody rings up and says, "Hey, you know, you've got to lock yourself up for a fortnight," people, you know, they can't afford to do it. They're not prepared. They have no preparation to do it. You know, they got to go shopping. They got to get themselves sorted out. Trying to, you know, there's a whole load of reasons why this doesn't work. And I tell you, I wrote a piece 2 or 3 weeks ago now where I looked at the TNT numbers, and I think I can't remember them statistically now, but just sort of kind of go with me on the example. There are about 18,000 people in that period, in that week, I think, who've been tested positive. And then something like 15,000 were handed to trick and treat. It's Halloween trick and treat. So we lost 3,000 there. And then they couldn't find another 3,000 of them, so we were down to 12,000. And then of that 12,000, they couldn't contact another 3,000. So I remember the figure, we were down to 9,000. And then when they tried to contact the 9,000 people, there were problems and people couldn't remember or didn't want to remember who they'd been in touch with. And then Sage weighed in and said, well, actually, if people who are supposed to be isolating, only 1 in 5 do it properly. So you ended up out of 18,000 people, I think it was something like 1,900 who might have done it properly. So there's a lot of leakage in the system, isn't there? How do you think we could address that?
Well, I think that's why we need to go more local in our enforcement. I think also we need to make sure it's in people's interests to isolate if they're asked to isolate.
Well,
So the
we
financial
then
packages need to be
sorry, Jeremy, there's a bit of a delay on the line. Then we come, to the key issue, isn't it? I mean, people who are on a standard, a minimum wage, national wage, whatever, they're going to have 2/3 of that. They can't pay 2/3 of their bill. There are other benefits that they can apply for, but it's complicated. A lot of people who've never been on benefits in their life have no idea how to claim benefits. It's clunky. I mean, wouldn't it be better just to scrap all the benefits, scrap everything and say, if you've got to be self-isolated or we're going to close your business, we're going to pay you the national COVID wage, which is 93%, which is on full benefits, and the COVID benefits is what people could get. Why don't we just make it easier and say, we'll give you 90% of your money. That's the best we can do. Now, do the right thing.
Yeah, actually, just to sort of give you a couple of slightly more cheerful comments. I mean, first of all, well, one of the surprising successes of this pandemic has actually been the much criticised universal credit, which, with the rise in unemployment, I think they've seen their numbers go up 3- or 4-fold. And what people say in DWP is that the old complicated smorgasbord of benefits that we had before would never have been able to cope. And UC, which is computerized, has actually done quite well. I think there is an argument that we need to be more generous with people who are asked to isolate, just because there's a public health reason that you want people to comply immediately with an instruction to self-isolate. The one other thing I would say is, look, I've talked about those leakage issues, and we all recognise those are problems when it comes to the test and trace system. But I think we should recognise that we are testing now. We're probably going to be up to 500,000 tests a day by the end of October. It's the single biggest testing programme in Europe. And it's got to be part of the reason why, when a month ago we were told this virus was doubling every week, now we seem to be hearing that it's doubling every 2 weeks. So something is holding things up more effectively. As you say, there's always this 2-week delay, and so things could deteriorate more. But I think the counterfactual is that without doing this huge volume of testing, we would be in an infinitely worse position than we're actually in.
Yeah, all the roads lead back to testing. And I think, I don't know, you must have a huge post bag, as we used to call it. No doubt your inbox is bursting with quizzical people. Certainly mine is. I mean, the 3-tier thing, the difference between 1 tier and 2 tier is, I don't know what it is. I don't know why we bother with it. And then the 3-tier thing is the thing that everybody dreads. I don't sense there is a kind of national strategy in all this. I hate the word strategy because I'm in the Tom Peters camp of forget strategy and we should have tactics and techniques and be nimble. But you do have to have some kind of a plan. I mean, we've got this, Prime Minister whose big idea of strategy is whack-a-mole, and that's nonsense. And we got this knockabout in Parliament where, when he's asked questions, perfectly reasonable questions, he just turns it into sort of political comedy. I don't feel. I'm going to be honest with you. I mean, I left school at 15, started my first business at 16. I've looked after myself, and I'm 75 now. This is the first time in my life I've been frightened. I am frightened because I'm 75. I don't want to go out, and because I'm terrified of going to hospital because they'll put one look at my date of birth and say, shove him down the end. I'm frightened, and I have no confidence in Johnson at all. I mean, he just looks a disheveled mess. I've no confidence in what our strategy is. We seem to run from one firefight to another. I just feel we should be saying, look, stop. Let's stop, recalibrate, reboot. What are we trying to do here? I don't get any sense of that.
I think it is our strategy for tackling the pandemic is in a better shape than you and probably many other people feel. I was someone who argued we should have locked down earlier. I was someone who argued we should have been doing test and trace right from the outset. I wanted to do quarantining at airports. So I've been on the sort of the public health side of this argument right from the start. And in particular, I've been frustrated that we haven't been learning more from countries like Korea, Taiwan, Singapore, and Hong Kong. Hong Kong has not only have they not had a single death in a care home in Hong Kong, they have not had a single infection in a care home in Hong Kong. There are some, Taiwan has had 7 deaths, and they're right next door to China. There are some remarkable things happening in Asia, which I wanted us to learn from more quickly. I feel that actually a lot of those lessons have been learned. I think, for example, the infection prevention and control in care homes is in a completely different place now to where it was in February, March. I'm worried that we still haven't got weekly testing for NHS staff because of the asymptomatic transmission that happened last time in cancer wards and other places. And so I think we've still got to do better, but I think we are trying to do this. I think that Boris wants to do the mass testing. I think there's a nervousness in government about announcing a date because they then think if they don't hit that date, then they'll get crucified. But I actually think this is one of those moments where we have to look far enough ahead, and we have to give people that plan. People have to see this is the tunnel, and this is the light at the end of the tunnel, and this is the date that we're going to get there.
We don't have to give them a Gantt chart with when it's all going to happen. We just have to say, like, my objectives are these. I've got these 3 clear objectives. This is what I'm going to try and do. As it is, I don't know. All we get is a comedy turn. I don't know. And you can see the backbenchers are starting to turn against him as well. And the rumours as well as I do that he's not long for this job. But I have no confidence at all. Let's just talk about change the subject. Otherwise, I should turn this into a polemic. Let's talk about university.
Your speciality, isn't it, Roy?
Yes, exactly. Yes. Why stop me now? What about universities? Was it the right thing to send them back? I mean, now we can't get the kids out of university because how are we going to get them home for Christmas? We've got to bang them up for a fortnight and make sure mums and dads who've got cars pick them up and drive them home because we daren't put them on a train. We're in a
look, I think the answer to that is, when transmission levels are very, very low, you can make a case for allowing people back to university. And there are some places like Cambridge University, I believe, Bath University may be another one, that are doing weekly testing of students, which is brilliant. So they have a high degree of confidence that they will pick up asymptomatic transmission quickly before it spreads. So it's not necessarily one size fits all, but now that transmission levels are rising, I just think in a pandemic, you've got to be prepared to change tack. And you can make a decision. I don't think we can expect the government necessarily on the basis of incomplete data and incomplete knowledge and a brand new virus to get these things right the whole time. But by the same merit, if we make a decision and it turns out not to be right, then we have to change tack. And this may well be an example where that has to happen.
I think we're going to struggle to get the kids home for Christmas because we can't bring them home now.
Yes, I mean, it's impossible to know what the progress of this virus is.
Well, you can. You could do some modelling on the units, can't you? Because you can find out, when the first cases were reported. You can do the modelling on the maturity time for the virus, the viral load in confined spaces, the number of people there are. I mean, we could model it, and I would have thought the modelling was going to take us well beyond Christmas before you can say, Mrs. Brown, your son's coming home.
Well, maybe, but these models have proved to be fiendishly difficult. I'll tell you what worries me most about the universities because I do quite a lot of these talks to young university students, is that in some quarters there's an idea beginning to take hold that it's okay for us to get COVID. because we're not going to be affected by it. We may not have any symptoms, and if we do, they'll be mild, and it's not going to kill us. And people seem to have forgotten this absolutely vital public health message that it might be fine for you, but when you go home to it might be fine for your mum and dad. When you go home and meet them for a weekend, you could pass it on to them, could be completely asymptomatic, because we know about half of all transmission is asymptomatic. But when they then go and see your gran or their grandpa, you pass it on to them, that could be fatal. And that really important public message about the fact that it's not just about your own health, it's about the health of the people that you come into contact with is so critical.
We've not done that messaging. Look what happened in Liverpool a couple of nights ago, you know, and it comes down to leadership, Jeremy. It's, you know, you may not like what I'm going to say, but if we had someone who looked like a leader, who spoke like a leader and gave us a vision like a leader, leaders are visible, have a vision and share it often. If we had somebody who did that on a national basis and connected with people, then I think we might get a much higher level of compliance. Let's talk about Public Health England, because when people knew I was going to talk to you, they said, ask him about Public Health England. So I'm asking you about Public Health England. I think two things. First of all, a lot of this is down to you, because you cut their budgets by 40%. And what do you expect? They were, you know, they worked their asses off to get where they are. And the reorganization of Public Health England is bizarre in the middle of a pandemic with Brexit round the corner. What are they thinking of?
Well, let me take the two those two things
in your own time.
Yeah, we had austerity when I was health secretary, and I was part of the cabinet that signed off on that austerity. But the truth is, and we protected the NHS, although we didn't increase its budget in line with demand, but the budget itself was protected, and then in the second half of my period started to go up a bit. But yeah, we had austerity. The austerity affected the non-NHS part of the health department budget, including Public Health England. But the result of that austerity, and I don't want to make a party political point here, but I do need to explain it as you challenged me on it. The result of those difficult decisions taken in 2010 was that we had a very healthily growing economy in 2014-15. And in 2018, I was able to negotiate that 20 billion rise in the annual budget of the NHS, which I don't believe I would have been able to do.
Is that another division?
No, it's not, don't worry. I don't believe I'd have been able to do that without those difficult decisions. So for me, you know,
but that was the NHS. We're talking about.
Yes, that's right. But then you start to
you directly. You knew what you were doing.
Yeah, exactly. But there are other parts of the broader health budget, and it's not just public health, by the way. Social care is another one, and I wanted to get a 10-year funding settlement for the social care system, just as I wanted to get that for the NHS. I got 5 years of funding and a 10-year plan for the NHS, and I was told, yes, we'll do that, but not now. And so you take a bird in the hand, and you know, 2 years on, we still don't have that plan for the social care sector. After this year, the year of the pandemic, when we've seen how absolutely bloody brilliant care home workers are, people going around door to door looking after vulnerable people in their homes. If we're not going to fix the social care system after a pandemic, when the whole country has seen how brilliant they are, then we're never going to do it. So it's absolutely now or never for a 10-year plan for the social care system, a long-term funding settlement for the social care system.
I'm going to just interject you there. I'm going to come back to the reorganisation of public health, but I did a podcast the other day for Carers UK, which is an organisation of voluntary carers, you know, family carers who give up their jobs to look after people. And I was just amazed. I mean, we all kind of know that there are people who look after their relatives because, you know, that's the right thing to do. They love them and that's what they do. But the extraordinary pressures that are put on family members when they look after people, and particularly in COVID, I mean, they've just had an awful time, Jeremy. it's one of these things. Well, you know, we really must do something for them. I mean, I don't know what doing something means, but we really do need to look more closely at the wretched.
Well, let's be honest about it, Roy. So in one way or another, we're going to have to pay more tax.
Yes,
if
exactly.
We want to look
but
after
you said you were
people.
agnostic. You said the other day you were agnostic on it.
I was agnostic about how we do it, but it is going to be more tax. You know, you know, there are loads of different ways you could do that, but I do think it's going to mean more tax. And my argument is the one tax that we have had for social care in the last 5 years has been the precept on council tax, which George Osborne gave councils the right to raise council tax by an additional 2% on top of whatever raise they were doing. Now, council tax is one of the most unpopular taxes, but there has been no public pushback.
No.
On that tax. People know we've got to put more money into social care. Germany and Japan have both had a version of a special social care tax for the over 40s. And in both countries, again, they've had no public pushback because people know you've got to do this with an aging population. And so I think this is the time to bite the bullet on this. The sums of money are large. You know, this is a bigger percentage increase than the NHS.
They're not large. If we share it amongst all of us, I mean, we have an NHS that you know, if you get run over by a bus, you get fixed up. If you don't get run over by a bus, then we'll use your money to fix up somebody who did go under the bus. That's, you know, socialized medicine. It's like getting old, isn't it? Some people will have, you know, a fantastic old age and die on a golf course. Other people will have a wretched old age with dementia. And I mean, you don't know where life's lottery is going to, and happenstance is going to take you. We should syndicate that. We should all pay that tax together.
I totally agree. I totally agree. But when I say large, all I mean is that, you know, the health foundations say that demographic pressures and rises in the national living wage mean that the adult social care budget needs to go up by 4 billion a year by the end of the Parliament. DILNOT is another 3 billion. So basically just those two together is a 40% rise on the current adult social care budget. So they're not rounding errors, but I agree with you. If you spread it out in a tax and it's what you want is risk pooling, to use the kind of word the professionals use, because that's what you do in a civilized society. You say, it doesn't matter who you are, I want every older person to know they're going, and indeed disabled adults and younger people too, to know that they're going to be looked after properly. That's what we all want.
I think it's easy to sell as well. I mean, some MPs are saying, oh, there should be a tax when you get older and we shouldn't tax the young people. But if you say to the young people, we're going to add a bit to your income tax so you can look after your granny, I don't think many people would say no to that. I really don't. Do you think the spending review, I suppose, will we have a spending review? I was thinking about whether the spending review.
Yeah, we will have a spending review. I mean, whether we have the full one before Christmas, I think it's more likely that they'll push the budget back till sort of March and do it then. But we're actually doing a select committee report.
It won't be a balanced budget, that's for sure.
No. We're doing a select committee report ahead of that spending review. In fact, we're hoping to publish it next week on social care funding, because that spending review, as you'll know, Roy, it's a once in a Parliament moment to sort this thing out. And if we don't, you know, hit the nail on the head in the spending review, it then becomes very difficult to sort out later.
And never were there more graphic reasons for us to sort it out now. I mean, I'm pretty sure the public would go with you. I want to take you back to public health. The reorganisation now, I mean, I just despair. Why?
Well, I think first of all, I don't think we should be blaming Public Health England for the problems we've had in our pandemic response. I'm sure they're not perfect, but you know, the truth is that, you know, the decisions were taken on the basis of the advice from SAGE. I think it was wrong that SAGE didn't model test and trace until April, but you know, ultimately ministers take responsibility for these decisions, but I don't really see PHE as being a big part of those early issues. And I hope that nothing happens in terms of reorganisation that distracts people from the important work they do. However, the long term, we talked about the blind spots, you know, when I was health secretary that's planning for flu, not for SARS-like respiratory diseases. We do need something like the Robert Koch Institute in Germany that has a specific mandate to scan the world for the types of pandemics and make sure ministers are getting the advice and make sure that we're basically preparing for them. And that was definitely a gap, by the way, not just in our system, but in France, Italy, Spain, and the United States. The whole Anglo-Saxon, North American, Western European scientific establishment got this wrong. And Germany, although they got it right, they probably got it right by accident, because they happen to have a decentralized health system where the health minister isn't able to make these decisions for the whole country in the way that happens in other situations. So we got it wrong in the West, they got it right in Asia, and we need to make sure that next time, if this thing comes from Africa, we don't get flummoxed again.
No, and interestingly enough, you talk about the decentralized system in Germany. They capture data differently as well in the different federated areas. So the data that comes out of Germany, I'm not saying it's crooked data or anything, but it's not captured in the same.
Not as good as ours, for sure.
No,
it's not as good as ours.
So, when they say, oh, they've only had 3 people with COVID or whatever it is they're claiming, it's not right. That there are probably a lot more cases, and we just don't, because there is no central way of collating data. There is no WHO template, as you know. It's done differently in different countries, and that's where we got into trouble in the early days, when everybody who died was ascribed a death by COVID. Let's so we agree that changing public health now is not the best thing we could do. Now listen, I'm slightly flummoxed, Jeremy, because we started late, and I
can go on for a little bit longer if you want, Roy, but it's entirely up to you. You might have other things to do.
We've got Zoom booked till next Tuesday, so we're fine. But I tell you what we will do. This is a great opportunity, John. I know we've got a whole stream. I can see them on my screen here. Huge number of questions. If we could do what they do at the Labour Party conference and take a composite of some of these questions.
Sure. I'll write down the questions and I'll answer them in groups. I've got until 6:15, Roy, just to let you know if that's.
Well, that's
just
terrific. Okay. Well, let's bash on.
Okay to aim for.
Yeah. Thank you very much.
No problem.
Right. Go on, John.
So the first one, I think there's a group of questions around. Bruce has referred to it, several others as well. Secondary health issues of COVID isolation seem to be growing. Suicides up, abuse up, cancer tests down, elective procedures down. What do you think the long-term changes need to be to make that good again, basically?
Okay. Do you want to tell me some other questions, and I'll do them in a group?
Yeah. Okay. Do you think or believe that social care will be supported, properly funded, and recognised in a spending review? Should
We've done that.
Review
We've
happen?
done that. No, you can't answer the same question.
We've got a slightly tongue-in-cheek question or two from Rekha, who says, "What would you have done differently if you were still Secretary of State?" And somebody else has said, "Are you looking forward to being appointed Prime Minister?"
Okay,
I saw the answer you gave Kay Burley to that question.
Yes. Okay, let me just go through those. So they're very well. I would say they're all good questions, apart from the last one. But so according to the government's own figures now, we think that there's basically one indirect death from something the NHS was unable to do during lockdown, as for every direct death caused by COVID. And I haven't seen any evidence of an increase in suicides, but that may be true, but I haven't seen any data on that. But I do know that mental health referrals were down by 40% at one point. And we all know with mental health that early intervention is absolutely critical. We know there's been an impact on cancer care, but also we know, probably most troublingly, that the number of people going into hospital to have heart attacks or strokes dealt with actually went down. So that presumably means that more people died at home than would ordinarily have with those conditions. So I'm sorry to sound like a crap record on this one, but literally the only way you can deal with that, if you don't want that to be repeated as we go into a second wave, is weekly testing of NHS staff. because you've got to have confidence that you are picking up on the asymptomatic transmission. The SAGE papers show that between 5 and 11% of all COVID hospital deaths happen to people who picked up the infection in their own hospital. And that is actually quite shocking when you start to think about people ought to be confident that when they go to hospital, they're not going to pick up an infection like COVID. And it turns out what we did well was we had problems with PPE, but most hospitals got to the point where they were doing PPE properly in their COVID wards. But what we didn't do well quickly enough was social distancing away from the COVID ward, so staff mixing in canteens and that kind of thing. We're doing it now, but the only real way you root this out is weekly testing of staff, and we've really got to get to that. As I mentioned, I think it's now or never on social care, and I will certainly be campaigning very hard to make sure we do bite the bullet on it. What would I have done differently as Secretary of State? Well, obviously I'd have taken some different decisions, but I'd have also made some different mistakes. And I feel for Matt. I think he's got indefatigable energy, and sometimes looking at the challenges he's had reminds me of my own challenges with winter crises that I had for 4 years in a row. They're incredibly draining and difficult to deal with. And each year you swear that you're going to never repeat it, and you're surrounded by people who tell you, yep, if you do this, and if you give me this money, I can, near as damn it, make sure that we don't have a repeat. And we never succeeded in stopping that happening year in, year out. And so it is a very challenging business being responsible for the 5th largest organization in the world. Am I looking forward to being PM? I think that I've enjoyed stepping back from the government in the last year much more than I thought. That's for personal reasons. I've got 3 young kids, and they were all born when I was in the cabinet, and I was kidding myself that I was being a great dad by doing stuff with them on Sundays. But it's not until you actually step back from those jobs that you realize that you probably weren't being as great a dad as you want. And that's before we start talking about whether I was a good husband or not, which I'm sure Lucia would have some views on. But what I would say, and I hear what you said earlier, Roy, about Boris, but and I'm not asking for anyone to take sides politically, but I do think it's been a good thing to have a government with a majority. I lived through 2 years of hell when we had a hung parliament, and I think Boris got an 80-seat majority, which has meant that we have at least had political stability during this pandemic, and I think that has been something that has been immensely beneficial.
It's an interesting point. I mean, it's the lack of decisive leadership that I think disappoints me as someone who's studied leadership for most of my adult life and taught it at university. Can I just interject, John, if I may? Carol Sikora was my guest the other day, and we talked a lot about cancer and trying to recover from cancer. It was a pretty gloomy prospectus, actually, that we got from Carol, who, clearly he's from the private sector and takes a view on he's a fairly right-wing guy, but it is so difficult now, isn't it, to see how, with hospitals having to be apply the same rules for social distancing as a hairdresser's or a pub, that we lose 60% of our capacity, isn't it? Some hospitals are working at 30% of their capacity because of the regulations. Do you think there's a case for having hospitals with different social distancing and different rules, because we ought to be better at infection control and better at it than, and I'm not being disrespectful for hairdressers, but it's a hospital, for God's sake. It's our job. We ought to be able to do that kind of stuff. Is it worth changing rules, do you think?
Well, I think we are getting better at infection prevention and control, but this is a disease where you know, what the SAGE number is, I think 67% or 68% of people have no symptoms at all.
Yeah.
And that is the bottom line, that, you know, unless you're,
back to testing.
it comes back. But I would say on cancer, the worry is that, you know, we're probably operating at about 80% of our pre-COVID capacity on cancer, which means we're 20% down. And, you know, we need to be operating over our current capacity to deal with a backlog. And this is a disease, as we all know, where time is of the essence. So
I think it's interesting. There was an announcement that the NHS is going to do some kind of like pop-up diagnostic facilities, get the kit out of hospitals. Yes. So you can do, which is fine, except if you're in tier 2 lockdown, how the hell is that going to work? And of course, once you've got a test and it says, yes, you've got a cancer, well, then guess what? You can't get in a hospital to get it fixed. So we're going to have a whole load of people without a date tests.
Yeah. Well, that's why I think we've got to crack this. You basically need to have hospitals as, you know, as near to COVID-free as damn it. That's the issue, and that's what we've got to get to.
We keep coming back to testing, and I've been persuaded of that argument since you first expressed it. John, let's have some more.
Sure. Kay asks, if we're moving to regional solutions for COVID, would it be helpful to have regional health configurations?
I love you, Kay. Wherever you are, I'm going to do a Donald Trump. I could come and kiss you. I love regions.
And then I've got a secondary follow-up thing. The Institute of Healthcare Management is creating a workforce well-being special interest group. And I wonder if you've got any thoughts or opinions around how we maintain and support the well-being of very hard-working health and social care workers during the terrible pressures that they're all having to undergo.
Okay. Well, look, on the regional configurations, one of the sort of little commented...
Don't you dare say you're agnostic.
I won't say that. I'm saying one of the little commented changes during my time as Health Secretary was that I inherited the Lansley 2012 Act, which in a way is taking the purchaser-provider split to its ultimate conclusion, hospitals as freestanding entities, you know, regulated by Monitor. But actually, with Simon Stevens between us, we spent most of that time breaking down the purchaser-provider split in order to set up system health, population health systems. And I think it is the right direction of travel. So I basically think we've got to have integrated care. The Lansley Alan Milburn model works well if the main model of care you've got in your mind is hips and knees and people who need a discrete health episode dealt with, where it's fine to say, well, choose a hospital down the road if they can do it in half the time. But when you're talking about people with multiple long-term conditions, older people who are going to be regular visitors to the health service, then what you need is a single care plan, an integrated package, whether it's health, social care, GPs, hospitals, community care. And that's why I think you need a system-wide approach. So like you, Roy, I'm a supporter of that approach. Workforce wellbeing is something that my select committee is just opening an inquiry into burnout amongst NHS and care staff. We're very concerned about it. And I don't want to prejudge what we say, but we're going to be looking at things like mental health support for staff. We're going to be looking at the particular issues faced by BAME employees. We're going to look at the issue of compassionate leadership, which is a very interesting one because I've never met an NHS manager who isn't, you know, a thoroughly decent, compassionate person. But my question is, do we put them into a straitjacket with all the targets that they have to meet that makes it difficult for them to lead in a people-centric way?
But when you were Secretary of State, you handed out a fair few targets.
Not that many. I think I had 1 or 2. Dementia diagnosis was a new target, but I was pretty good at trying to avoid new targets. I'm not saying there weren't one or two, but I certainly I knew there were always risks in new targets. But the one point I'd say, John, overall up to that question on the well-being of staff, is that what most people are worried about is a very, very basic question: are they getting burnt out because there aren't enough doctors on their shift? There aren't enough nurses, there aren't enough AHPs on their rotas. And if we're going to really attack the issue of burnout at the root, we've got to have a people plan which says in 10 years' time, we need this many nurses, this many physios, this many endoscopists, this many doctors, and so on. And we're going to start training them now, because it takes 7 years to train a doctor, 11 years to train a consultant, 3 years to train a nurse, and so on. And the people plan doesn't have those numbers, because basically the Treasury wouldn't allow DHSC or NHS England to put those numbers in the people plan. But it's absolutely essential that we do have those numbers, because I was very proud that I increased the doctor and nurse training places, midwife training places by 25%. It was one of the biggest ever increases, if not the biggest ever increase. But it may not be enough, given the pressures we face, and we may need to go further.
Jeremy, I'm just hustling you a bit because I've got another time. It's 11 minutes past 6. And also, we've had more interest in joining the NHS than we've ever had. I think hits on the NHS Jobs website have gone up 200%. I mean, there are going to be a lot of people who are redundant with good skills, good education, and could, I'm sure, work in the NHS. It's a great career to join the NHS. It's tough, but it's a fantastic place to work. We will have a surfeit of applications, and I don't see anything happening from Health Education England. We talked to Pranav Izar about this, and of course, that's not her role. Her role is just the Health Education England have got to do the recruitment. I mean, if we miss this opportunity, we'll miss it for a whole generation. We really should be solving our workforce problems now once and for all, because we could recruit, I would think, very easily right now.
It's a really good point. I agree. I agree with Roy. How about
wow, that's the end of your career. That's
except on the CQC, I agree with Roy.
Yeah, well, I guess we've had the battle over the CQC. I think they're going down the tubes anyway. Right, John, what have you got? Cheer us up. Give me one more question, and then I need to.
Well, we've got one from one of our much valued sponsors this evening. Adrian is asking, why should we still have devolved budgets between health and social care? Why couldn't there be some kind of legal undertaking just to bring them together and just do away with this divide once and for all?
Well, I agree with that. I think we should do that. I think the reason it hasn't happened so far has been because when budgets were tight, everyone was protecting their turf. Then when the NHS got a substantial increase, they felt they didn't want to take on the risks of the pressures in the social care budget. So if you then give the social care system a decent increase, then you have the opportunity to do that. The only thing I would say is that as we merge the health and social care systems, let's not get too sucked up into big organizational, institutional changes, because they can be incredibly time consuming. Let's look at those changes from the patient's point of view. I think what the patients want is a single budget for that patient, a single care plan for that patient, shared across an electronic health and care record that everyone who looks after them, whether in their care home or in the hospital or the GP surgery, everyone is accessing the same care plan, the same record. That seems to me to be what we should be focusing on, the things that patients notice, not necessarily the organizational things.
When you look at that, I mean, the one thing that worries me about that answer is the fact that social care is means tested and healthcare isn't. If you move the two closer together, that then becomes a very difficult boundary to manage. Which bit of healthcare will become means tested, or which bit of social care that's means tested now becomes free. I mean, there is a political decision there that's tough, I think, for policymakers to sort out.
Well, this may be famous last words, Roy, but that in my time as Health Secretary, we actually had people who merged the health and social care systems in their areas. I think Suffolk has done some very good work on that. And that issue just was the dog that never barked. People understand that there are some, they're going to have to pay some care home fees, and they understand bits of the package have to be paid for. And we didn't have this big debate and big complaints. I mean, what annoys people now is the rank unfairness of the fact that, if you get cancer, your whole treatment is paid for from start to finish. But if you get motor neurone disease and you end up, or dementia, and you end up being incapacitated, you can be cleaned out. And so that's the bit which I think, the social care reforms need to address.
Jeremy, I know on the time, it's 6:15. Just give me something you think that's good that's come out of this, about this whole COVID thing.
Well, first of all, I think people have realised the importance of health and care in a way that didn't happen, wasn't always the case. I think the social care system, for those of us in healthcare, we always knew how important it was. It wasn't always front of mind for the public. I think that's been great. I think that lots of people have realised the importance of family life and social interaction in a way that perhaps we took for granted. I think we had become a bit too kind of focused. Those of us that weren't rushed off our feet trying to keep hospitals safe. I think we'd all got on the hamster wheel of life, and this has forced us to come off it, and that's not always been a bad thing, frankly. So I think there have been some positives, and I think also we're learning about technology, doing these kinds of things by Zoom. I don't think that's going to go away. So I think there have been some positives in a pretty awful year.
It has been, yeah. We've got, on the 21st of October, we've got Change Day coming up again, and we're majoring on no going back. The good changes that have happened, and some really fantastic stuff that people have done, and we're going to try and sort of cheer ourselves up with that. Listen, can I just say, Jeremy, thank you enormously for your time. I've very much enjoyed talking to you. You've been very frank, and thank you. I hope everyone's enjoyed it. I'm sure they have. Listen, good luck with the select committee. Anytime you want me to come and give evidence, just let me know. Can I thank also our sponsors, Docobo and Allscripts, that's Richard and Adrian. So thank you both very much. We can't do these events without sponsors, and we're very grateful to you. If you're watching it live, good evening. Thank you very much. If you're watching a recording, look out for the next one, and let me hand back to John.
Thanks a lot, Roy. I've got a dash, but good night all.
Thank you.
Nice
Bye-bye.
Thank you.
Thank you.
Thank you. Well, just before we close down, John, because we're not constrained by the time, I don't think. A comment from our sponsors. Richard, what was your view?
Oh, I thought it was a very good, interesting conversation. I think you covered a very broad range of topics. I think, and Jeremy, it's refreshing to see an MP who's back on the back benches after they've been in cabinet with a lot more sort of honest and straightforward answering than you would find when they were in cabinet. So I really enjoyed it. Thank you.
Yeah, I thought he was frank, and he admitted the fact that he made a few foul ups whilst he was in office. I quite like that. Adrian, what do you think? You give him a job working for you?
Yeah, he looked a lot more fitter and weller than he looked many years ago. Maybe with douse in the Foreign Office would help that. But I was encouraged really with his whole focus on the need for social care and the need to look after people in their own homes. If you can reduce acuity, you reduce admissions into hospital, you reduce admissions into care homes. So that was.
And he's absolutely right. We've just really got to sort ourselves out with testing. Okay, John, over to you.
Well, I'm just having the privilege, really. First of all, thanking you, Roy. You've worked hard there this evening. You can have a cake, perhaps, in the coming week to celebrate. By the way, speaking on behalf of the Institute of Healthcare Management, we are having a bake-off competition, and you'll read about that in your weekly e-letter tomorrow. So do stand by for that. That's going to be an absolute thriller. Our next Health Chat is with Alistair McClellan, the editor of the Health Service Journal, and that's on the 2nd of November. Do please tune in for that. We've already got a very good audience building for that. And then Richard Beacon, the Chief Executive of Walsall Healthcare NHS Trust, is generously agreed to be our guest on the 15th of November. All that remains for me to say is thank you all for tuning in this evening. I do hope you enjoyed it. We work very, very hard to make sure that our IHM members get full value for money. It was very interesting to get a number of social care questions this evening, and all the better because we're delighted that Jane Brightman has joined us as our General Manager for Social Care, and we are going to be making a very determined effort to attract our friends and colleagues in social care into the Institute. So for now, all that remains to say is thank you very much for joining us this evening. Do hope you enjoyed it, and we look forward to seeing you at another event very soon. Bye-bye.
Good night, everybody. Thank you.